Welcome to this deep dive into surgical pathology. We're going to format it like an exam to help you review some key introductory topics.
We'll be covering neoplasia,
Wow.
and non-neoplastic growth disorders, and then also how to classify neoplasms based on cell type and their behavior.
Perfect. Sounds good. Let's get started with neoplasia.
Okay, so a neoplasm, as defined by Willis, is an abnormal mass of tissue.
What makes it abnormal?
It has three key characteristics: uncoordinated growth that exceeds what normal tissue would do, and persists after whatever the stimulus was is removed.
So essentially, it's a growth that's ignoring the body's stop signs.
Exactly.
How do we categorize these growths then?
We classify them into neoplastic and non-neoplastic growth disorders.
Okay, so let's focus on neoplastic disorders first.
All right, so neoplasms are further categorized as either benign or malignant.
And malignant neoplasms have an additional layer of classification, right?
Yes, so they can be either primary, meaning they originated in that location, or secondary, meaning they've spread from somewhere else, metastatic.
Okay, got it. Now, how about classifying neoplasms by cell type?
So this is where histogenesis comes in. It's the cell type from which the neoplasm originated.
Okay, so a neoplasm arising from epithelial cells could be,
A papilloma, adenoma, or carcinoma.
and from mesenchymal cells.
A fibroma, lipoma, or sarcoma.
Okay. What about neoplasms originating from multiple cell types?
Those are more complex. So you have things like pleomorphic adenoma, fibroadenoma of the breast, and Wilms tumor. All arise from multiple cell types within the same germ layer.
Okay. And what about neoplasms from multiple germ layers?
Keratomas, and those can be either benign or malignant.
Okay. Moving on to classifying neoplasms by their behavior. What distinguishes benign from malignant tumors?
Okay, so benign tumors are non-invasive and resemble their tissue of origin. They grow slowly, have normal nuclear morphology, well-defined borders, and rarely exhibit necrosis or ulceration.
So they're generally well behaved. What about malignant tumors?
Malignant tumors, on the other hand, those are invasive, and they are capable of metastasis. They may not resemble their tissue of origin, grow rapidly, display abnormal nuclear morphology, have irregular borders, and often show necrosis and ulceration.
So those are kind of the red flags we watch out for.
Indeed.
Okay. Now let's shift gears a little bit and talk about non-neoplastic growth disorders. Starting with hyperplasia, what defines it?
Hyperplasia is an increase in organ or tissue size due to an increased number of cells.
Do these cells mature normally?
Yes. In hyperplasia, the cells maintain their typical size and morphology.
Can you provide some examples?
Sure. So physiologic hyperplasia, breast and thyroid enlargement during pregnancy. Pathologic hyperplasia, you would see adrenal gland changes in Cushing syndrome, or thyroid changes in Graves' disease.
Okay. Moving on to hypertrophy. How does it differ from hyperplasia?
Hypertrophy is an increase in organ or tissue size due to an increase in cell size, not cell number.
Okay. And can you give us some examples?
So physiological examples would be muscle growth with exercise, uterine enlargement during pregnancy, and then pathologic would be like cardiomyopathy.
Okay. Got it.
Yeah.
What about hamartomas?
Hamartomas are essentially tumor-like malformations with a disorganized arrangement of tissues that are normally found at that site.
Okay. Do they grow uncontrollably like neoplasms?
No. Hamartomas actually grow under normal body controls.
Okay. Examples.
Peutz-Jeghers polyps in the bowel, and hemangiomas.
Okay. Let's discuss metaplasia. What is it?
Metaplasia is a reversible change of one differentiated cell type to another. It's an adaptive response to injury, irritation, or altered function.
Why would one cell type transform into another?
Well, a lot of times it's a protective mechanism, but it also carries risks.
Okay, what kind of risks?
Areas of metaplasia can be more susceptible to malignant transformation. They can also be misdiagnosed, leading to overtreatment.
Okay. Examples of metaplasia.
So you see this with Barrett's esophagus due to reflux, bronchial changes due to smoking, the cervical transformation zone due to HPV, and bladder changes due to chronic irritation.
Okay. Finally, let's talk about dysplasia.
Dysplasia is essentially disordered cell development with increased mitosis and pleomorphism.
Is it considered cancerous?
No. Dysplasia actually lacks the ability to invade and metastasize. But severe dysplasia, or carcinoma in situ, is considered a precursor to cancer.
Okay, got it. Let's move on to carcinomas and sarcomas. What are they?
A carcinoma is a malignant tumor of epithelial cells, and then a sarcoma arises from connective tissue.
Do they have different patterns of spread?
Generally speaking, carcinoma spread through the lymphatic system, while sarcoma spread through the bloodstream.
Are there any exceptions?
Yes. Follicular thyroid carcinomas can spread to bone, but it spreads via the bloodstream.
Okay. Before we wrap up this part of our deep dive, can you just summarize the key differences between benign and malignant neoplasms?
Sure, so benign neoplasms are well differentiated, localized, slow-growing, and typically harmless, unless they're compressing nearby structures. Malignant neoplasms are invasive, capable of metastasis, often poorly differentiated, and can cause significant damage.
Okay. Let's quickly review hyperplasia, hypertrophy, hamartomas, metaplasia, and dysplasia as well.
Okay, so hyperplasia is increased cell number, hypertrophy is increased cell size. Hamartomas are disorganized masses of normal tissues with controlled growth. Metaplasia is the reversible change of one cell type to another, and dysplasia is disordered cell growth.
Okay. That's a good overview of these fundamental concepts in surgical pathology. Let's continue our deep dive in the next part, exploring specific tumor types and their classifications.
Now that we've laid that groundwork, let's delve a little deeper into how we actually evaluate tumors.
Okay, so what are the key aspects that we need to focus on when we're examining a tumor?
So we consider its gross appearance, so what it looks like to the naked eye, a microscopic feature, so what we see under the microscope, and then, if necessary, we perform special studies, like immunohistochemistry or molecular testing.
So it's kind of like detective work, piecing all the clues together.
Precisely.
So what do we look for during the gross examination?
So we observe the tumor size, shape, color, texture, location, borders, consistency, and invasion into surrounding tissues.
Okay, and then we go deeper with microscopy.
Yeah. Microscopic examination reveals cellular details, like cell size and shape, arrangement, nuclear morphology, and mitotic activity.
We're looking for any signs of abnormal behavior at that point.
Correct.
When do the special studies come into play?
So immunohistochemistry helps determine the tumor's origin and type by detecting specific proteins.
Okay. And molecular testing.
Molecular testing analyzes the tumor's DNA or RNA to identify genetic alterations that are driving its growth or that might influence its response to treatment.
It's remarkable how technology is enhancing our understanding of tumors these days.
Indeed.
So how do we classify this vast array of tumors?
The most widely used system is the World Health Organization, the WHO classification of tumors.
The WHO classifies tumors.
Yes. The WHO classification system considers the tumor's histogenesis, histological features, molecular characteristics, and clinical behavior.
So it's a pretty multifaceted approach.
Precisely.
Can you give us an example of how this system works?
Sure. Let's take breast cancer. So, breast cancer is not a single disease, but a diverse group of tumors.
Yeah. I've heard of different types of breast cancer, like ductal and lobular carcinoma.
Right. So those are two common histological subtypes.
Can you elaborate a little more on those?
Sure. So ductal carcinoma in situ, DCIS, that's confined to the ducts, while invasive ductal carcinoma, IDC, has spread beyond the ducts.
Okay. And lobular carcinoma.
Lobular carcinoma in situ, LCIS, that arises from the lobules. And then invasive lobular carcinoma, ILC, has spread beyond the lobules.
What other factors contribute to breast cancer classification?
So we also consider the tumor's grade, which reflects its aggressiveness based on its microscopic appearance.
And hormone receptor status.
Yes. Hormone receptor status indicates whether the tumor cells express receptors for estrogen and progesterone, which can guide hormone therapy.
Okay. What about HER2?
So, HER2 is a protein that promotes cell growth. HER2 positive breast cancer overexpresses HER2, which can lead to more aggressive growth, but can be targeted with specific therapies.
So tumor classification is really important because it guides treatment strategies.
Exactly.
This is fascinating, but I imagine there's much more to tumor classification that we can cover here.
Absolutely. Each tumor type has its own unique features and classification systems.
What other tumor types should we explore?
Let's move on to gastrointestinal tumors.
Gastrointestinal tumors. That's a pretty broad category. Where do we even begin?
So we can categorize them based on their location in the GI tract. So the esophagus, stomach, small intestine, colon, rectum, and anal canal.
What are some common esophageal tumors?
The most common malignant esophageal tumor is adenocarcinoma, which often arises in the setting of Barrett's esophagus.
That's the metaplastic change we discussed earlier.
Yes, the glandular epithelium in Barrett's esophagus increases the risk of adenocarcinoma.
What about other esophageal tumors?
Squamous cell carcinoma is another type. It's more common in the upper and middle esophagus, often linked to smoking and alcohol use.
Okay. Moving down to the stomach, what kind of tumors do we see there?
Adenocarcinoma is also the most common type of stomach cancer.
Are there any other notable stomach tumors?
Mucosa-associated lymphoid tissue lymphoma. Mulk lymphoma is another type, often associated with chronic inflammation caused by Helicobacter pylori infection.
So even bacterial infections can contribute to cancer development.
In some cases, yes.
Are tumors of the small intestine very common?
No, they're relatively rare compared to tumors of the colon and rectum.
Okay. What about colorectal tumors?
Colorectal cancer is one of the most common cancers worldwide. The vast majority are adenocarcinomas.
Any other types of colorectal cancer?
While adenocarcinoma is the most prevalent, we also see carcinoid tumors and lymphomas.
This diversity of tumor types,
Hmm.
even within a specific organ system, is quite remarkable.
It reflects the complexity of the human body and the ongoing challenge of understanding and treating these diseases.
Our journey through gastrointestinal tumors has been insightful. What other areas should we explore?
Let's venture into the realm of soft tissue tumors.
Soft tissue tumors. Sounds intriguing. I'm ready for the challenge. So, soft tissue tumors, where do we begin?
Well, soft tissue tumors arise from mesenchymal tissues, so the connective tissues of the body.
Meaning like tumors originating from muscles, tendons, fat, blood vessels, nerves.
Exactly.
And they can occur anywhere in the body.
Correct.
Okay. So what are some common types of soft tissue tumors that we see?
Well, soft tissue tumors can be benign or malignant. Lipomas, tumors of fat cells, are a common benign example, as are leiomyomas, tumors of smooth muscle cells.
Oh yeah, lipomas. Those are like those common subcutaneous lumps that we see.
Yes. Those are usually harmless.
What about leiomyomas? Where do those typically occur?
Leiomyomas are commonly found in the uterus, where they're often referred to as fibroids, but they can also occur in the gastrointestinal tract and other locations.
What about malignant soft tissue tumors?
Malignant soft tissue tumors are called sarcomas. They're less common, but more aggressive.
Can you give some examples of sarcomas?
Sure, so liposarcoma is a malignant tumor of fat cells. Leiomyosarcoma is a malignant tumor of smooth muscle cells. And then rhabdomyosarcoma is a malignant tumor of skeletal muscle cells.
So, are sarcomas difficult to treat?
Treatment typically involves a combination of surgery, radiation therapy, and chemotherapy. It's really tailored to the specific type and stage of the sarcoma.
So, multidisciplinary approach is really essential.
Absolutely.
Well, this deep dive into surgical pathology has been a really comprehensive review.
Yeah. We've covered a lot of ground, from neoplasia, non-neoplastic growth disorders, tumor classification, and even explored common tumor types in various organ systems.
And it's important to remember, this is just an introduction to a vast and fascinating field of surgical pathology.
Always keep learning, keep exploring.
Yes. Keep those minds sharp and continue expanding that knowledge base.